How's it going, guys? Medium difficulty question for Repro. Before we start, please subscribe to my channel. I really appreciate it. Give the video a like. Really appreciate it. Find me on Instagram. Mehlmanmedical, Mehlmanmedical, links down below. Find me Telegram, links to the Telegram group channel down below. And let's start the clip. So, 24-year-old woman here. She's got irregular menses for the past 2 years, and we're being intentionally vague because we want you to think about the differentials for what could cause oligomenorrhea. And we've got this ultrasound here, which NBME USMLE will show you a very similar one. I probably used this image in prior YouTube clips. We got 1504 here on the questions, but this is showing you polycystic ovarian syndrome. Got multiple cysts here. Okay, so she would have hirsutism as well. Now you got to think about, well, what's the mechanism for anovulation, but we're going to talk about that. So what's most likely to be seen in this patient? Choice A, decreased LH, increased FSH is wrong. So when we have high BMI female, that's the type of demographic that's going to get PCOS almost always. Can it occur in normal BMI? The answer is yes, but it's usually high BMI. That means insulin resistance. Insulin resistance causes abnormal GnRH pulsation. That leads to high LH, low FSH. Choice A, wrong fucking answer. Choice B, theca interna cell stimulation that's decreased is wrong. So you have to think, I'm going to ask you watching this, which cell in the ovary does LH normally act on? I'm asking you. Acts on the theca interna cell. The theca interna cell makes androgens. So if LH is high, we said LH is high, FSH is low. So if LH is high, then we have more theca interna cell stimulation and we get more androgens. That's why we get hirsutism with PCOS. You're like, holy shit, I didn't realize it was that simple. Yeah, it's that simple. So FSH, what cell does that normally act on in the ovary? It's granulosa cell. What's the granulosa cell secrete? Estrogen. Fuck am I saying? Aromatase, which will convert those androgens from the theca interna cells into estrogens, right? And also inhibin. So if you have high LH, we get hirsutism, as we discussed. If we have low FSH, we're also going to have poor follicular development, follicle stimulating hormone. Okay, so if you have poor follicular development, rather than getting a ruptured Graafian follicle and the follicular remnant, what do we call that? I'm asking you. It's called a corpus luteum. So if you get poor follicular development, you're not going to get a ruptured Graafian follicle. You're not going to get a corpus luteum. Now, the corpus luteum normally secretes what? I'm asking you. It secretes progesterone. So if you're not ovulating and you're not making corpus luteum, you're not going to secrete progesterone, right? So progesterone limits the growth of endometrium. Estrogen stimulates the growth of endometrium. So if you have no progesterone production because you're not ovulating, we have what's called unopposed estrogen. Now, I'll ask students sometimes about estrogen, progesterone, and PCOS. And they're like, oh, estrogen's high. And that it's like, it's not that estrogen is necessarily high per se. It's that we have unopposed estrogen. That's the phrasing I want you to remember. So it shows up all the time. So unopposed estrogen means we have endometrial hyperplasia, and that's going to increase the risk of endometrial carcinoma later in life. You've been following my content, you know I've talked about this tons. So choice C, wrong fucking answer, because we would have a widened or a thickened endometrial stripe. Now, I know some of you aren't doing 2CK3, it doesn't matter, but the endometrial stripe you could infer would be, well, that could refer to the thickness of the endometrium, right? And you need to know for even step 1 that you have endometrial hyperplasia. It's all over the NBME exam. So you have a widened, a thickened endometrial stripe, okay? Wrong fucking answer. Choice D, positive progesterone withdrawal test, correct answer. Now, the presence of progesterone followed by the loss or withdrawal of progesterone is what causes menses. So when normal menses occur, you have the corpus luteum secreting progesterone, and the corpus luteum is going to degrade after 7 to 14 days because fertilization doesn't occur. Normally, when you get fertilization, you get the syncytial trophoblastic cells of the placenta secreting HCG, and HCG's role is to maintain the corpus luteum so that progesterone can be secreted to maintain the endometrial lining of the pregnancy. So if you have withdrawal of progesterone, whether it's normal with menses where the corpus luteum breaks down and you lose progesterone, or you artificially do it with progesterone withdrawal test, an abrupt withdrawal of progesterone is going to cause increased PGF2 alpha in the endometrium, which leads to spiral artery vasoconstriction and ischemia and apoptosis of the superficial endometrial lining, hence menses. So in PCOS/anovulation, we have a functional endometrium. Estrogen levels are normal, if not slightly increased. So we have a withdrawal test where when we pull progesterone away, we're going to get sloughing of that endometrium. We get menses, the positive progesterone withdrawal test. So a positive test just simply means your estrogen levels are normal. It means that your lining of the endometrium can build up normally. If it's negative, it would mean you have an estrogen deficiency of some kind. And it could also be a structural abnormality, like Asherman syndrome. Okay, that's where you do a dilatation curettage and you cause scarring of the endometrium. And you get uterine synecdoche. Okay, those are the names. That's the name for the fibrous adhesions you get with Asherman. So that's 2CK3 mostly. But the point is, you have a thick endometrial lining. You're going to force an artificial menses with the withdrawal of progesterone, and you have a positive test with PCOS and ovulation. Let's just eliminate the other wrong answer here. So fecal lutein cysts wrong. So these are benign incidental cysts you can get in the ovaries bilaterally due to HCG in early pregnancy. So these are what are, in polycystic ovarian syndrome, these are called follicular cysts or anovulatory cysts. Fecal lutein cysts, in contrast, they'll tell you on the USMLE, they'll just say, woman's last menstrual period was 3 or 4 weeks ago, implying she could be in early pregnancy, but not know yet. And she's got some dull pain bilaterally, or ultrasound shows some cysts bilaterally. You just need to know they're a benign finding and you don't have to treat them. Okay, so wrong fucking answer.